And welcome to this special episode of The Dental Guys. I'm Wes the Dental Guy.
And I'm John the Dental Guy. And yes, Wes, this is a special episode. We have the president of the Academy of Osseointegration coming to us for an interview. And Wes, let's talk about, for those of you who are just maybe listening to this for the first time and wondering who we are, maybe you're associated with the Academy. Mm-hmm. And you're maybe wondering what AO even is, if this is maybe, you haven't been listening to us for a while. Wes, let's go back. Let's go back to where we first, you and I, because this is way before we knew each other, how we first got involved with the organization and why we have stuck with it. Wes, kind of tell that story a little bit.
The interesting thing about the AO is it's been around as long as I've been a dentist, actually longer. And in dental school, it just so happened that John and I received the same award. We were in two different dental schools, and there was a student implant dental award, and we received that. And you received a free subscription to JOMI.
Because it was the Academy of Osseointegration Award.
Yeah.
To outstanding student in implant dentistry.
And I don't know what I did. I don't know what I did,
At the time,
John.
I was interested in implants, and I did some stuff, and I did maybe a little extra, and I asked the right questions.
I think that's what it was, the right questions.
And they saw that maybe I could be interested in this. But at the time, I had no idea really what that meant or really a lot about the organization until I went to the first annual meeting. Now, both Wes and I had read the journal for years, and it was 2 years after I got out of school, 2 years after, I went to my first annual meeting, and it blew my mind. It blew my mind. I mean, here we had, there were things there that I had never seen, which is what you want. And there were people there from the clinical side and the research side and the educational side. At that time, even more specialist driven, although it was starting to change and still is, has a ton of specialist involvement and a lot of educational involvement from residencies and things. But as you're going to hear Dr. Stanford talk about, there's been a real push by this organization to get general dentists as well involved in the organization, which I think they've been very successful with doing, to have a real, team-based approach, synergistic approach, multidisciplinary approach. And Wes, we have kind of had this little bit of an orbit even around Dr. Stanford, because going back to when you and I met in Sweden at an implant meeting, which is so random, he was there giving one of the big presentations. I mean, he's been around implant dentistry with a company that both you and I had worked with years ago, very heavily involved in research, and also now is the dean at UIC. I mean, he's really kind of been one of our dental heroes.
Yeah, dental heroes. We really like having someone of this caliber on the show, and it really helps to kind of share what he has been kind of up against recently, not only in education, but the decisions that they have to make as the AO continues to grow. John, you talked about how the AO has grown since we kind of got involved years ago, as it's moved from mainly, a placement organization where you have surgeons, maybe some prosthodontists, and now it's really all encompassing. And whenever we say that, what we're saying is that there's always now, from here forward, there's a big push at the AO to bring people together, just like we've talked about in one of our previous episodes with Dr. Lemke, is that the AO is all about bringing people together, whether it's through a journal and you're having a conversation around a table, or bringing people together in your backyard, right? Sitting around drinking coffee or having a drink, and you're talking to your surgeon and you're trying to learn how to communicate better. And then maybe even if we get back to going to meetings someday, and I think we will, it's going to be maybe a little bit different. But there's still this growth that Dr. Stanford is talking about, and they're looking at ways to really bring our profession together.
Yeah, and we always like the fact that if you go to if you get involved with certain implant organizations, they are kind of more of a, hey, this works in my hands, so I'm going to show you what I can do. And hopefully it works in your hands. Well, the AO is not that way. They believe in science first. They believe in research first. Dr. Stanford, of course, has been involved with that his entire career. And they believe in doing things that are evidence-based. And I know that kind of gets worn out. Maybe in your mind, you think, oh, evidence-based. But it's really the truth. And that's one of the things that I think as general dentists, especially if you're listening to this, we should not be afraid to dive into, being in that world right along with our specialist colleagues of making sure that what we're doing follows best practices, best evidence. And I think you're going to hear the passion from Dr. Stanford on how the organization is trying to integrate with the changing market, the fact that there's a competitive marketplace. Yes, we know that's a business side of this, but we have to keep our standards high and we have to keep it research, evidence, science-based. And really, we have to be doing things at the highest possible level. So I think that as you listen through this episode, you're going to, I think, see why Dr. Stanford has a very forward-thinking approach to the future of education and meetings, and has some really interesting thoughts too, because we do get him to be clinical on things about implant prosthetic design, connection type. He's had a ton of
we asked him some really interesting questions, and I think it's up for debate still, about what some of the answers that he gave, what matters really. And it's a great debate, and we can't wait for you to hear that, because stay tuned for that. That's at the end of the show, right? And we asked that at the end of the show, but he's got some great things to say to you guys that are members and to non-members. I hope you're tuning into this. If you're listening to the Dental Guys side, if you're not a member of the AO, you should check them out. And if you're listening to this from the AO side and you're not a member, you should check it out and become a member, because there's great benefits to being a member. So we're excited to have Dr. Clark Stanford join us, and that'll be right next.
Well, hello and welcome to this episode of the Dental Guys in collaboration with the Academy of Osseointegration. We're bringing this special episode to you featuring the president of the Academy of Osseointegration, Dr. Clark Stanford. So, Dr. Stanford, welcome to the podcast.
Well, thank you, Wes and John. It's a great pleasure to have you, and thank you for taking the time to speak with me tonight.
Yeah, we're excited to have you on, and for those of you who don't know Dr. Stanford, I'm gonna give the official introduction, and then we'll give a little background as to how we kind of maybe first learned about him as well. So Dr. Stanford has been involved in education for a very long time, and most recently became the dean in 2014 at University of Illinois at Chicago, and distinguished professor there as well, which is kind of a big deal, the distinguished professor thing. We know that if you do a little research on you, and we know that he's had this educational background, and also has been involved with continuing education and in several different organizations, of course, with the Academy for quite some time. So the personal side of this, which is interesting.
Yeah, this is good, John.
Is that, if you guys have been listening to the podcast for a while, you know that kind of this started back years ago when Wes and I started having this ongoing Google Hangouts conversation about cases and research and implants especially. And that all began when we met at the Astrotech World Congress in Sweden in 2012. Wes and I met in Sweden, which is so weird. And you were there along with a good number of other people. And at that time, you were doing some presentations. And so, Wes, I think you used the word earlier before the show, fanboys. I think
John and I, we have been fanboys of Dr. Stanford for a very long time. It's a pleasure so much to have him on the show tonight and to talk about some high-level things. And let me tell you how much we respect Dr. Stanford. Recently, there was a article. Now, we are Geeks Corner, right? And we go right to the AO for the most recent updates to a lot of information. And we had a mentors meeting the other day surrounding an article that Dr. Stanford headed up and collaborated with other individuals about antibiotics in implant dentistry. And if you haven't read that article, let me just tell you, we have changed some things in our protocols because of some of the things presented in that article. So starting off with a little Geeks Corner, this is how much we respect the Academy and how much we are fanboys of Dr. Stanford. Welcome to the show.
We have to say that, because this is a big deal. And one of the things that we really wanted to talk with you about as we begin here, really getting into some meat of the topic here, is about dental implant education, because we know that obviously the academy is very much invested and has been for a long time. Really, that's how it began, was all surrounding how can we best place and restore dental implants. And so we're interested because you've had so much experience from the educational side and the postgraduate level and the dental school, dental student level, all the way into the kind of the cutting edge of what you see at an AO presentation that's brand new. So we just want to get a feel from you. What's the current status of dental implant education? How are we doing? And maybe beginning with kind of the postgrad level. And what's being done well, and where are we headed? And that's a broad topic, but we just like to kind of hear your thoughts on that.
Thank you, John and Wes. It's actually, to a degree, a difficult question to answer, very short, in a brief amount of time. But the best thing to think of is when implantology really became mainstream in North America was because of the advent of bringing together a set of specialists working together in a true interdisciplinary manner. And that's why we were able to do a lot of the initial basic clinical research that actually showed and documented that, in fact, implant therapy was a predictable treatment for tooth replacement approaches. To that end, where the academy was created was to be able to bring as a common playground, if you want, of all the specialists that would normally kind of hide in their little academies and just talk in their little academies and never want to kind of share what they knew with other specialists who could actually complement their expertise. And so the academy came about in many ways to be that playground where all the specialists could come together and kind of let their guard down just a little bit. And that also allowed the threshold to come up in terms of what was expected, because everyone was expected to be performing at the top of their abilities. So when you talk about postgraduate education, we're seeing the same thing happening where originally, yes, oral maxillofacial surgeons were the ones primarily placing. Periodontists were kind of let in a little bit later, a little bit of controversy. Now what you're seeing is, as has happened many times with technologies in dentistry, as the technology becomes more comfortable and more widespread and the risks as well as the limitations are better understood, you're actually seeing that in many ways the therapy is expanded to a wider variety of providers throughout the profession. And that's what we're seeing now with implant therapy with many other specialists. And of course, there are more general dentists placing implants now than all the specialists combined. So the key thing, though, is understanding patient evaluation, understanding the actual. It's easier to talk a patient into an implant than sometimes it is to actually place and predictably restore the implant. And I say that because a lot of providers, until they have gained a lot of experience in a variety of different ways, and I know we're going to touch on that, how one gains the knowledge and the experience and the training, if you will, is critically important so that the provider actually understands the risk that they may be walking into with that particular patient. And that particular, both the patient themselves, the medical issues that the patient presents, and of course, the dental issues that need to be assessed. Postgraduate programs have been doing this well for a while. Yes, prosthodontics under the CODA accreditation now is surgically placing implants. The issue is each of the specialists, though, still recognize that when they get out into practice, the best way to maintain a vibrant specialty practice is to understand your limitations and to be able to work as a team, especially on those difficult cases where you will have a specialist colleague that will help and bail you out when you get into trouble, but they're not going to do it very often. And so that's this issue of really understanding the boundaries of what you're getting into. And I'm going to tell you, there are some specialists that are excellent providers. There are some that are, they could probably go back to school a little bit. There are some GPs that are absolutely excellent providers that are equivalent to anything I've seen with a specialist. So I think it's really the specialist generalist model. It's not as much the title. It is your experience and your training, and especially your understanding of risk management and when to work as a team and when you can work as a solo provider.
Now, let me ask kind of a follow-up to that idea of the multidisciplinary side. of what's going on at the Academy of Osseointegration and also in post-grad world, because you mentioned kind of the order of things sort of went from surgical specialties, kind of began this journey. But now that we've come sort of full circle to really everything being restoratively driven and prosthodontically driven, how is the postgraduate side doing with actually having the surgical specialties truly understanding the restorative side of things? Because that seems to me like it's always been the disconnect and the struggle, even to the point where, prosthodontists have of course begun implant training and to be able to have at least one idea behind that being having more control over certain things. But how well do you think that the surgical side is really understanding when they come out of specialty training, the relationship of where these implants need to be placed to achieve the best restorative outcome?
That's an excellent question, and I think the best way to answer it is the advent of a variety of imaging technologies and the software programs that have come out over the last 15 years to be able to do simulation surgery, so that the oral surgeon or the periodontist actually has a better understanding, because many of these treatment planning approaches actually needs a diagnostic restorative component that's built in either place in the patient's mouth, or it's virtually designed based on the imaging of the face or the imaging of the ridges. But by doing that, the oral maxillofacial surgeon and the periodontist is actually understanding better what are the restorative needs of the referrers. Because in the end, a complication needs to be actually predicted ahead of time, and that's what the software does. Now, periodontics does have, as a part of their specialty, they do have to do some restorative care to actually understand some ways the limitations of the other side of what they've done. But that's simply to help to connect and complete the circle of what they saw in the virtual world in the diagnostic and treatment planning phases, which we all should be doing and working as a team.
So basically technology has kind of become an answer to that world. And I think we're seeing more of that every time we go to courses. It's much easier to show somebody an anticipated result. And so you can see what a deviation of 5 degrees at the apex does to you when you extrapolate that out in a digital wax up. And I could see that, and I'm glad to hear that's kind of where we're headed, because I feel like you can't learn prosthodontics and surgery in your residency. And so if you're learning surgery, there's got to be a quicker way to at least start to understand that. And let me ask maybe one more follow-up question. I know Wes has got a question too, but the different schools have, it seems like, different specialty programs that, if you will, are maybe driving that ship a little bit. You have some schools that seem to be driven more by the surgical side of things or more by the prosthodontic side of things. And does that make a difference, do you feel, still where you go to school? Which program you go to, whether you will get that balance, or do you feel like it's becoming more standardized now to where you can go to a lot of different places and come out with kind of the same basic beginning knowledge when it comes to specialty training?
Well, the smart-ass answer here is come to UIC because we're the best. But
set you up for that.
But no, the reality is that because of the competency standards that we all have to match, there is a basic threshold of knowledge that we all are providing. Where the differential comes in is the access to technologies, and most schools are getting pretty good at that. Some schools are struggling with a range of patient care because they may be located in an area that doesn't have a patient volume of a range of cases that are as easy to come by. But I'm going to argue a lot of it comes down to the quality of the faculty. And it's the quality of the faculty that are engaged, that are staying up to date, and I would hope most schools have that, and being able to kind of push the edge, because what we do in terms of human endeavors is the ability to improve means we have to constantly feel maybe a little uncomfortable. And that's how we actually then know we're on the edge of constantly improving. And to feel uncomfortable by myself, all I am is I'm uncomfortable. But if I'm with a team and I'm uncomfortable, I can look to my surgeon and say, okay, what do you think about the way I'm thinking on this? And use an example is jaw in a day, which we do quite frequently at the school, where the first time I looked at someone's leg and said, well, okay, we're putting the implants there, and I've already pre-designed my prosthesis, and that's defining where the implants are going in the leg, and then all of a sudden this big piece of bone moves up to the jaw, and then all of a sudden when I look and do my final impressions, it's like, darn, that's pretty close. And it's like, I would have never thought I could do that. And that's what a team does.
John, you just sent me a message, and it was the exact question I was going to ask. We are so in tune with one another. Now, here we had the opportunity to interview an educator, Mark Ludlow, on the podcast, and I know you know Mark, and he's doing some high-level things down in South Carolina. Actually, Medical University of South Carolina is where he's stationed at as an educator, and he's doing some things with pre-doctoral dental students. Let me ask you this question. How much do dental students know right now about dental implants, and what are we doing to change maybe that?
So, I mean, dental education has been evolving since I was a dental student in the 80s. So, yeah, I know it's been a while. But it's constantly I made the comment earlier that one of the things that's happened is dental educators, by and large, many of them are specialists. And what we have had to do is get to the point where we actually understand the range of outcomes that we can do. So then we have basically been able to now understand what a beginning, what I call a novice provider, what do they need to know to understand their risks to be able to provide it. And so I can speak for the two institutions I've been most recently at. We teach a comprehensive didactic. We teach a comprehensive risk space. We teach, of course, a comprehensive restorative. And then we have a selective for implant surgical experience for some students who have that particular interest to have that exposure in dental school. I would argue, though, to finish dental school, I would be reticent to say you're ready to practice routinely implant dentistry. It takes quite a bit more to be able to be ready to feel where you understand where your boundaries or where the guardrails are of the kinds of patients you should select to do as a solo provider and what you should do as a team.
And that leads to the actually kind of a nice segue is as we move from even pre-doctoral students to graduating as a dentist, and you know some risk, you know a little bit about implant therapy. As we move into the real world per se of a practicing clinician day in, day out in a private practice, and then also as we move from even a prosthodontist might move from education into practice, and a periodontist moves from education into practice, I think it would be good for us to hear about the state of education, continuing education in raising the level of implant knowledge, and where do people start? I think that would be a great question. We've asked this before on the show to other people, but where do you go? Let me ask you this. If you had your dream, if you were a dental student and you weren't going to postgraduate, where do you go? Where do you start? What do you learn first?
So where do you, as an institution, or where do you learn in terms of the approaches that you're...
Well, more continuing education. If you were to say to a graduating dental student, or say they've just graduated they've just finished a GPR, they're ready to begin private practice without post-grad training, would you say, how would you direct their continuing education journey?
Get a good mentor. Get a good mentor who you trust. It doesn't have to be in your town. It could be through Zoom Dontics, which is what we're doing right now. It is in any forum where you have a trusted advisor, where you can let your guard down and you can have an honest conversation, and they can be honest with you, like, hey, Wes, this is right in your barnyard, go for it. Or, maybe you should hold off and do this other. Historically, that's been in what we call study clubs. And the study club model has worked a lot because it has this. For younger providers, I actually normally strongly, and I've been had the opportunity to work with and lecture and do hands-on with a number of practices that have these continuums. And I find for especially people who are kind of building their repertoire of understanding, a continuum where it may be a group of colleagues get together and they have 4 days together, they then break, and then 2 months later they have another weekend and they do another set of exercises. Then all the time they're treatment planning, and then they come and they bring their patient cases, they all talk about them as a group. Then there may be some surgical care that may be mentored if they would like that by a periodontist or a surgeon or whoever. And then it's over typically a year-long period, but it's building confidence. When you may not, a novice provider leaving dental school, they may have taken out, at my school, probably 100 teeth. They may have done a few perio procedures, but they don't really feel that comfortable, and they really want that set of training wheels to really get the confidence so that they can actually continue to build their repertoire. I get nervous, and I'll lay my cards on the table, where I get nervous is if they go just for the weekend course, they buy the kit, and everything looks great on a sawbone model, but the first time they look at a patient and they realize laying a flap is kind of hard work, the kit goes in the closet and the implant company goes, where did that customer go? So that is where having a group of advisors, a group of colleagues that you trust and you can let your hair down, so to speak, that I think works well.
John, here we are again talking about mentorships. The same thing that we urge anyone listening to this, that if you're interested in taking it to the next level, as we like to say all the time, Brannemark said, surround yourselves with people that are better than you, and you're bound to succeed. Great minds around you all the time, being humble enough to receive criticism, and having someone that you can let your guard down with. This is the key to success, and it's not
it's interesting because we're going to be, I think, depending on how everything rolls with the AO meeting next year, talking a little bit about this
John.
Potentially. We were asked, it was kind of like, whoa, amazing, but to present on some of this stuff because social media has become an interesting world because mentorship used to mean something that was very personal and it was very interactional. It was in-person discussion. It was, even maybe it was sending cases through email, or it was, photos and things like that. And social media has kind of taken on this little bit of a double-edged sword with what mentorship means. And, you've got kind of the before and after beautiful shots, with 27 steps in between that are not shown, and people think that this is easy. And then on the other hand, you have some really good positive uses of social media to help to push, what's possible, and to show the failures and the mistakes and the things that people can learn from. And so we think that that world, we continue to urge, especially our younger clinicians, to not focus so much on that only, but to really seek out the real world. And we feel that's one of the values of, say, going to like the AO annual meeting, is it's, you can't really fake it as much. You have to sit there and interact with somebody, and they'll ask you a question. And if you don't know the answer, you really, you can't just run away, and I think that sitting and receiving that knowledge, speak to that, because you've been in this world of education since the 80s, when the only way to get on the podium most of the time was you had to have published some things, and you had to have done some things, and you had to have proven yourself, and it was peer review was the whole name of the game. And that's changed in the social media world, right, in some ways. So do you still see the value of the in-person education, the meeting, the lecture format, talk about that versus what you're seeing with some of the virtual education that's going on. How effective can that be? I know you're probably in the world of virtual so much now, even with COVID. How can this work? Can it work? And or is it more of a problem in some ways?
So I'm going to answer as a politician. I think it's going to be a long time before people will be that comfortable being in a room of 7,000 to 10,000 people, arm to arm. And I think that's just the social reality right now. It will come back to a degree, but it does question, do you go to a large meeting for the education and networking component, or do you go to the large meeting to literally learn something that you already know? This is kind of the running issue with continuing education is when you talk to most healthcare providers, physicians, nurses, PT, dentists, when they go for continuing education, they almost always go to forums or meetings or sessions that they already know a lot about. They don't go to the session they don't know anything about. And so this is kind of the challenge when we start thinking what I call hybrid models, where you have a hybrid model where you could do an online to push yourself into an area that you're uncomfortable, but you would never kind of admit that you were at that kind of national, or you would never want to spend the resources to go to a national meeting. But now you suddenly find, well, gosh, maybe I need to understand what they're doing in dermatology to be able to adapt to what I'm doing in my soft tissue grafting and how I then can delay and create a different incision, because the world of, I'm thinking in my mind, the world of ophthalmology and ophthalmology surgery has treated and trained and changed a lot about how incisions are made. And so, but you wouldn't as a dentist ever go to that meeting, but you could do it in a hybrid forum online, and then you take it to a larger forum meeting where it evolves into what we might be doing then in the profession of dentistry.
Man,
so
that's
it's
a challenge.
It's a blending. So I believe the future is going to be a blending of, we haven't talked about this as a board, but I believe the future is there's going to be smaller regional meetings that people will feel more comfortable traveling to, but you're only talking 100 to 300. And we may have more hybrid learning that is just in time when you need it in your own practice. And then we may have fewer, larger forums that people get together, partly because people, I think, will become more comfortable learning in this forum. If anything, we're forcing grade school and high school kids to learn this way right now. So
that's right. Whether they like it or not.
Yeah.
It takes a lot to make something big very personal. And that's what we've lost in some of these bigger meetings. Yeah. And it really is the after dinner or dinner conversation where the mentorship and the learning happens. John, how many times, and I know Dr. Stanford's right here with us, have we sat down and just drew on the napkins and we've studied and we've talked about the things that we've heard or things that we already know and understand. And John, this is a state of the art in education, and I want to kind of segue, because we'll be respectful of the time of the listener and Dr. Stanford. I want to move to this. Is the current educational model in how we learn to place surgically, implants and to restore them, right? If I didn't receive any education in my GPR or in my doctoral training or even in my postgraduate training, if I'm an oral surgeon and I want to know more, or if I'm, a prosthodontist and I want to start placing, rather than going back to school, there's several current models right now where we might go and just do a bunch of implants, maybe in a foreign country, right? Maybe even locally, we might do some placement, and we might have some didactic, and we might have the mix of sawdust model. We might have pig jaw. There's all kinds of mix. Tell us about the state of the art and how that relates to where we're at currently, your dream of where it is going, and maybe where we're at currently, and what is the AO really doing, right, to influence this? Because we believe the AO, John and I do, has had great influence on implant dentistry. Okay. Now we're biased, right? We're not paid to say this, but we believe that the journal, the Academy Journal, is the greatest implant journal in the world. And so what is the Academy doing to next level your dream of education? Like if I want to go and learn, there's a lot to unpack in what I just talked about. So let's unpack that in the last part of the show.
So there's the best way to unpack this is to recognize that we need areas where people, the human, if step back in time, humans are tribal. Humans learn by stories. That's the most powerful way that you remember, because you put yourself into the context of the story. Oh my gosh, I've seen that patient. Or oh my gosh, I have seen that mess up. Or, oh my gosh, I've seen the perfect case that shouldn't have happened. And every one of us feels that near miss. And that's a story we all can remember. It takes, though, the recognition that the specialists and the GPs have to be able to be in a common forum where they do have that trust of each other. And rather than the power of the podium, they have to understand that the person who is presenting does have data, does have information, and does have knowledge, each of those have a different definition, that actually builds to being able to have evidence for what they are presenting to that audience, given the risks and given the limitations of the learning curve that each of those people have had. People rarely talk about the learning curve at the podium. And so that's one of the things. We are starting a new initiative, which I might as well throw out here. It's called Doc Matters, which is actually a closed environment where AO members will be able to share cases, share images, share a lot of information with each other in small group forums. It's a monitored forum, so it's not like a chat room on the outer internet. It's actually an enclosed environment. But again, it's this idea of I can reach out to a colleague in Germany, for instance, present it because I know he has had a lot of experience with this issue or this complication or this type of patient issue, and we can have that intimate conversation in a closed environment where we know that something that we say, we wouldn't really want it out on social media because it would be misunderstood. This is one of the things that we're doing now, is to create those safe spaces, if you will, for our members to be able to share, because that's how we learn as co-mentoring. And the mentor-mentee role always has to switch back and forth. And so that's one of the important things of what we're trying to do with this initiative.
And we see too that, that we know that the AO has developed fellowship recognition and certificate program, because the other side to, and I think maybe part of where Wes was kind of going a little on this too, was, with all of these different models of continuing education leading to, say, surgical placement of implants, there's discussion about which ones are, if you will, legit. What is how do you legitimize the training that you have completed to show that you are, ready to place.
I mean, because you can
implants.
go to a weekend warrior course and start placing dental implants, right? Because I'm a dentist, and as long as I recognize I'm holding myself, if I recognize I'm holding myself and analyzing risk factors like you've brought up so well, that if you get that comfort level in one weekend, right, or just whenever, I mean, you just feel like you want to start placing implants, right? You've read enough books. You can do that. But I really want to, I want some influence from an organization, right? What is the AO doing, right? Or what are they thinking about doing?
So I'll start with my favorite quote, which I've often used in my discussions, and that is Niels Bohr, a Dutch physicist, said, "An expert is someone who's made all the mistakes in a very narrow field." And it's an important thing to remember. And so one of the things that the AO is doing is we are creating a staged set of recognitions of the training, but also the experience that someone has, because training is basically like training wheels. It gives you a lot of the basics, but then as you build experience over your career, you gain more and more, and that pushes you to continuously improve. So one of the things that we're doing now is creating a staged approach to have the Academy recognize not just the training, but the expertise that the individual Academy member has. This is going to start with a reformatting of the certificate program. It's then going to move to a mastership level, a master's, if you will, and then it will move to a diplomate status. And the master's and the diplomate status is going to be a combination of both documentation of your experience as well as evidence through a format of an examination to be able to verify that you truly have accomplished and you truly understand the body of the training and the expertise that you now have.
It's good.
So this is a process that we are starting right now. We've worked through, it's been approved by the board, and it's being rolled out this year, and it's a part of our new strategic plan for the Academy that in my year as the president of the Academy, we are actually implementing the strategic plan that was started by Dr. Jay Malmquist in his year last year.
I think
Now,
it's
how does
important.
that-
Yeah, go ahead, John.
How does that affect? So I think it's awesome, because I think that gives that with an organization like AO where people know what it's about in general when they get involved with it, that it's based upon research and peer review and science. And I think that contrasts with some other groups that are not as focused on that. They're more just based on, let me show you what I can do. And we feel that works great a couple times, but not in everybody's hands. And it's important to have that research basis and that scientific basis. But if you look at that, then you start to, I guess, filter maybe the type of training you would choose. If, say, you are a general dentist who is wanting to get into implant placement, if you have a program like that and the AO says, here's our criteria for what we see as being, a vetted clinician that is a master in this specific area, it kind of gives you a bit of a lens that you can look through at a training program, and you could say, this fulfills the criteria, or at least part of the criteria that moves me closer to this status. And is this going to be aimed primarily at, say, general practitioners who are wanting to, or is this going to be really just for anyone who wants to achieve this status? What's kind of the thrust or the focus of that program as far as the type of clinician that you're wanting to see involved?
Well, I think, John, it's going to be really for any member who wants to do it. Yes, it probably would initially appeal to more of a generalist who may not feel as much, but I don't think that's how it's going to evolve. I think it's going to evolve, and you're going to see a range of different people that are interested in the mastership and the diplomate status, because what it's showing is you're actually performing and you have documentation of your expertise at the top of the profession, recognized by all the specialties that are members of the Academy. So that's where the special, I think, recognition comes from this.
Cool.
And, I think it's important to note that the committee that is putting this together and approving these things is a mix, right? And there's perio, there's pros, there's OMFS, and there's 3 GPs on this. And I think it's fantastic. That's one of the things about the Academy that John and I have just really noticed over the past, 10 years, is that they want to be inclusive because, of all the specialties and the GPs, because they know that you said, there was in the pre-show, you said that the general dentist subs out, right? We're subbing out a lot of work to our specialist. And I think it's important to kind of, and I want you to talk a little bit about that analogy, and why the AO, is so interested in, everyone, right? Because we use
I think the distinctive that I see with AO compared to some organizations is that rather than say we're going to drop the bar to allow everybody in, it seems that you guys have come from the approach of we want everybody's level to be higher, and we're going to try to basically set the bar, but encourage those who maybe haven't quite gotten there to there's a path to get there. And is that sort of the approach that you're taking? And talk a little bit about that with especially the general practitioner in mind.
Yeah, so I use the analogy that much like building a skyscraper, it takes a general contractor with many, many subs. If you want a skyscraper that's going to stand for a long time, it takes actually understanding all of the issues that are in play, and that actually takes a team to do that. And that's where the role of the value, because maybe the best, pardon the analogy, the best plumber can do the best plumbing, the best electrician can do their role, the best structural engineer can do their role, but working together, they create a masterpiece. And creating a masterpiece takes literally all of these people working together. And I think that shows then the value of where AO has always been around. And we come back to our earlier comment, what works so well with this is the fact that if you have it comes down to communication, and where you could have a GP refer, for instance, a patient to an oral surgeon, and the oral surgeon says, John, this looks great, but recognize there is a medical issue here that we uncovered in further evaluation. Or a periodontist says, listen, there's a soft tissue issue that we've uncovered under further evaluation. The patient in the end is treated better. And in the end, that's what we're all about here, is that, to have the best patient outcome. And I wrote an editorial recently, which I call TIE, like a bow tie, TIE, and that is the best way a team works together is through trust. And then through trust, you build integrity of the team, because you know each other, you hold each other accountable, and that's the only way you reach excellence, which is how you tie this together. And that was this idea of, but the basis is trust. And that's where this team concept comes from.
Well, that's the first, in the 5 dysfunctions of a team, right? That's the first failure. It's a lack of trust. That's the primary failure in most teams. And I think that building that together by having these kind of common, goals or common learning pathways, common expectations, that allows everybody to have something to shoot for. And I love that. I think that I'm excited, Wes, to hear what the organization's doing to push that forward, because I think we as general practitioners who have really tried to as best we can, learn from the best and have a team approach, feel that that's, what we need, because we see so many GPs that are sort of floating around, not necessarily, they're kind of bouncing around from different place to place, not having that clarity. And I think part of it is we're not asking enough of people. Sometimes I think people will say, oh, you're asking too much. I think it's that we're not asking enough. And I think when you give people a clear push to say, hey, this is the standard that we want to be at, a lot of people will rise to that. And even if that just creates positive peer pressure to see, what's possible, hopefully that pushes the standard up, because the alternative is the commoditization of dentistry, and have it just be where an implant's an implant's an implant. And we all know that's not true. And it's also not easily reversible. So I want to change just as we kind of get closer to the end here. I want to respect your time, but I'm very interested to change, because we've been talking about education and touchy-feely things, which I love. But I also want to talk just for a moment about a little bit of implant science, because you've done a little bit of work over the years in that area. And so the best question Wes and I could come up with, there's so many things we wanted to ask you, is the following. And you've already had this, so you've had a time to maybe think about it. The way we phrased it was, rank which you view as most important for long-term dental implant success, and explain your thoughts. Connection or interface design of the implant, surgical placement technique, or the type of prosthetic used. So we're interested to hear your thoughts on that. You know, how each of these things affect long-term implant success. What are your thoughts?
Well, I'll speak to each of them quickly. The connection, you know, we've evolved from the external hex to some form of a conical connection, regardless of the platform. And I think right now, because of that, we've managed to actually reduce micromotion of the abutment joint connection. It's pretty stable now. And I don't think that you're going to see some dramatic changes there. You may see some design architectural changes, trying to achieve different things. Implant surgical placement, how do I say this nicely? It's a one-time in history event, but how history evolves around that implant is what's most important. So you can place an implant into what you think is good primary stability and good bone stock, and a year later all that bone is gone, and the surgical placement at that point is irrelevant. And in fact, maybe should be argued shouldn't have been done. I come down to, and you know, of course, as a pros person, I'm going to say this, if you don't create prosthetic contours that a patient can keep clean, it's going to fail. And I've seen many prostheses in the practice here in Chicago where I am practicing at the university, and these beautiful prostheses come in, and yes, they're monolithic zirconia, and it's gorgeous porcelain, and there's periimplantitis everywhere because somewhere along the line, everyone was focused on the pretty porcelain, but they forgot there was a human being that actually had to be engaged in the care of that prosthesis. And it's not unlike selling someone a very fancy car and not teaching them how to drive. And I'm sorry, you know, there is no such thing as car accidents. There's only driver accidents. And it's not being able to take care of the work that's been done.
So wait a second. Are you saying not everybody can just get a monolithic zirconia prosthesis, Dr. Stanford? Are you saying that lip support matters and flanges are a problem? I mean, come on. That's not popular.
What I'm saying is that there are different prosthetic approaches based on just remember the nice big flange you put on a patient who's 50 years old who has reasonable dexterity and can prove to you that they're keeping it reasonably clean. 3 years later when they stroke out and they cannot clean and a care provider cannot clean, that patient's completely different. So just that's why I say always keep in mind the prosthesis when you make it is made for a patient of that ability of your best estimate. But most people expect that prosthesis to last for a period of time and the patient's going to change and evolve underneath it. And we have to be prepared to adapt to that.
Are you also saying we don't know how to treat periimplantitis?
I would say it's better to prevent it than to ever try to treat it.
Yes.
Good answer. Good answer.
So if we're going to rank those, John, from what I'm hearing, is that the most important thing to long-term implant success is the restorative design. Number 2 would be, we've kind of, but let's just say that the connection is important. We know that we've found that better connections exist. And then number 3, surgical placement technique. According to Dr. Clark.
I'm talking about long-term outcomes.
Long-term, not short-term.
You're basically saying that if everything is controlled from the surgical standpoint and we have a good connection, those things we should know how to do well.
Right.
And then the challenge becomes our aging population, it sounds like, and medically compromised patients. And it is interesting that we're thinking so differently now than we were 20 years ago because the patients are living so much longer and, with polypharmacy and all the other issues that we're seeing. I think it's kind of cool to see how, the arguments over connection are sort of dying down a little, at least because I didn't hear. I mean, you really kept very calm through that discussion. No yelling or anything like that. So
John, I know what camp I live in.
I mean, yeah, we just did a 6-part series on the Zero Bone Loss Concepts book, and there's still some pretty some pretty interesting discussion going on. But I agree. I think we're kind of coalescing now down to where you're seeing a little bit more standardization, and now we can focus more on the prosthetics.
Dr. Stanford,
that's a great answer.
We really appreciate you being on the show, and I'm going to give you the last word before I close the show. But what I'd like to ask you to do is talk a little bit about the rest of the year and preparing for, I know we're probably going to have you, I'm hoping, back on the show. I think we had talked to the Academy about doing that, so I'm kind of putting you on the spot right now about that. But before the annual meeting, tell us a little bit about some things that the AO is doing to maintain connection to its readers and listeners over the next coming months.
Thank you, Wes. So many of the things that we're doing is we've improved the membership benefits. We've added an additional journal. We have this new platform that I just mentioned, the Stock Matters, that's rolling out this fall. We've increased significantly. We actually took practically the entire 2020 annual session and we moved it online through a whole series of repeat webinars. We're also going to have a webinar coming up here shortly about all of the highlights of the 2018 summit that I was the chair of, that was addressed some very significant issues in terms of implant dentistry. And we're having the three primary presenters in that webinar. So we're doing that. We're also preparing, of course, for the 21 meeting that is planned for Orlando. And like everything, as Dr. Fauci says, the virus is dictating what we can do, but we are planning right now for that meeting that will be in Orlando. How it will look is going to be, I think, really going to look like a hybrid of an intensive amount of online and face-to-face. And I think, as I made my comment earlier, in many ways, I think that is a reasonably okay future for how we get together in terms of professional meetings.
Awesome. Well, listen, if you're listening to this and you're not a member of the Academy, I want you to head over to Osseo.org, and if you're interested in knowing more about the annual meeting and this professional development that we're talking about, you click on that professional development tab on the website. It's like right in the middle of your screen, literally, and there's a little segment there called annual meeting. You'll see some things about the annual meeting coming up in 2021. I know you'll want to keep tabs on that, But even right now, if you go to the Online Learning Center, this is where I head all the time. And there are 2 journals that are now available to members. And John and I were super excited about that because that just doubles down on what you pay as a member to be a part of the Academy, which I think is a still, even with one journal, because we had both journals coming anyway. And in JOMI, the Journal of Oral Maxillofacial Implants, is the primary journal that has been there for years for the Academy. And then now IJPRD, International Journal of Periodontics and Restorative Dentistry. Now, it is a next level journal as well. We've talked about restorative driven surgery tonight as one of the primary reasons for long-term success. And that journal right there is going to be one of your go-tos for this particular topic. So yes, full circle back. I am, and John, we are fanboys of the Academy and Dr. Clark. And listen, if you're listening to this, the best thing you can do is follow the Academy on social media. They're on Instagram, they're on Twitter, they're on Facebook, and they're posting stuff all the time. I want you to look back, and I want you to look back for Dr. Lemke's interview with us that was recently released on how to maintain a great relationship with a specialist. That referring relationship is so important, and we talk about some ideas, tips, and tricks to kind of, work on that. And then we also talked with Dr. Malmquist back when his son and their their practice in Seattle and some of the things that they're doing in their practice. That was a great interview. And then, of course, this interview, and there'll be more to come. So much more is coming from the AO and the Dental Guys. You can follow the Dental Guys as well. Head over to the Dental Guys on Facebook, Twitter, and Instagram. We're on all that stuff, and we look forward to hearing from you. If you please give us feedback in the comments section, someone will reach out to you, send us a message, some direct message that we'll read, and just encourage us to continue doing what we're doing, because we love to hear the feedback. And I know if you want to reach out to Dr. Stanford and you have a question, leave that question in the comments section, and we'll make sure that the appropriate people get a hold of that and get that over to him. So for Dr. Stanford, for John, I'm Wes, and this has been another great broadcast of the Dental Guys and the Academy. Thank you so much for listening, and good night.
Thank you.